You can simply pause the video and you can try to figure out what is the problem in this ECG. Now, when we zoom in, you can try to see these leads, that is V1, V2, V3, V4, V5, and V6. We can try to find out the problem in these leads because these leads can clearly show the changes. Now, when we see the P wave is there, but it is not very apparent. If we try to find out P wave here, P wave is not very well visible here. So P kind of looks absent or very diminished here. You can make out P, but P wave looks very much kind of gone somewhere. Here the P wave is not at all there. So there looks to be a wave disappearance. P wave looks to be lost somewhere. Now, when we see the QRS, we can see that QRS is 151 milliseconds. Means the QRS is pretty wide. The QRS is pretty wide. If we try to see, the QRS is pretty wide. Here also, the QRS is pretty wide. It is almost three and more than three boxes. Here also, the QRS is pretty wide from here to here. So this machine is reading QRS of 151 milliseconds. So QRS is wide. The other things which we can see in this ECG is we see the T wave. Now, how is the T wave? If we see very closely, this is the T wave. So P wave is not there, QRS is wide, and T wave is very sharp and very tented. If we can notice, it is very sharp and tented. So if I want to describe this T wave, this is definitely a tall T wave. It is sharp, very sharp. It is tented or peaking. Peaking means usually how you get T wave which is symmetrical and dome shaped, but here it is very sharp and it is like tent. So it is tall, sharp, tented, peaking, and symmetrical wave. Symmetrical. How do we call it as symmetrical? Normally, if you draw from the midline of the tip, this and this distance is almost same. So this is a symmetrical T wave. Whereas in normally the T wave which we get is like this. So the T wave is not symmetrical. The T is always asymmetrical in normal T, but in this ECG, what we are seeing is a symmetrical, tall, tented T waves. Now, all these features, that is, tall T waves, that starts then with wide QRS and then loss of P, these are very typical features of hyperkalemia. This is very typical features of hyperkalemia. In fact, I have told this thing earlier also that if the potassium is between 76 to 7 milliequivalent per liter, what you get is tall T waves, which are peaking, which are symmetrical, which are tented. This is the finding when the potassium is between 6 to 7. When the potassium is between 7 to 8, the P wave disappears. The P wave disappears and then QRS widens. So in this ECG, this is there, this is there, this is there. When potassium is between 8 to 10, patient can have this VT, VFib, or cardiac asystole at any point of time. The cardiac asystole means heart will not at all contract. Patient will have a very bad hypotension, and if it is not treated, patient will die. And more than 9, patient will typically have sine wave pattern, that this wide QRS and this tall T, they merge and form this is a sine wave pattern where the you'll not see P, will not see QRS, will not see T, you'll see this pattern on the monitor. It means that the heart is not at all contracting. So these are very much urgent indications of treating this hyperkalemia. Otherwise the patient will simply die. The one of the most important treatment for hyperkalemia is GI drip. GI drip. Means what we give is 25 to 50% dextrose plus we give around 8 to 10 units of human atrapid or insulin or apidra. Any insulin will do except the long acting slow acting insulin. Apidra, short acting or atrapid will do, and we have to give this over 10 to 20 minutes. This can be repeated once, twice, thrice depending on the potassium level, and this can be very relatively seen whether the potassium is coming down or not by doing ECG, by doing ABG, or by doing the blood test for serum electrolytes. Other modes which can help is injection sodium bicarbonate. Injection sodium bicarbonate also helps to lower serum potassium. Other ways which can help is salbutamol nebulization, but it can cause tachycardia. So that is the limitation for the salbutamol nebulization, because many of the time patient may have VT, VFib, or patient may have tachycardia, and giving salbutamol can precipitate ventricular tachycardia, ventricular fibrillation, sine wave pattern. And other is the potassium binding sachets, but these potassium binding sachets usually take around 12 to 24 hours to act. So these are more of a use for those patients who are known CKD, or those patients who have hyperkalemia, but it is more of a stable. So this is a very, very typical and very, very classical ECG showing no P wave, wide QRS complex. Here it is, we can see it is 151 milliseconds, and tall tented symmetrical T waves, very, very typical of hyperkalemia. Thank you.